Good evening, everyone. We welcome you all to Ortho TV Online in association with Orthopedic Research and Education Foundation. To introduce today's topic and speaker, I hand over to the Secretary of Oref, Dr. Janki Badani.
Thank you, Neeraj sir. Welcome, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today, we have our chairman, Dr. John Mukhopadhyay, sir, who is teaching us about distal radius fracture. So over to you, sir.
Thank you, Janki. And today's talk is going to be on distal radius fractures, which is really one of the most common fractures that we have to deal with. And the learning outcomes would be to describe the relevant radiographic anatomy, decide on which fractures need fixation, plan your surgical approach, and you need to achieve adequate reduction and stable fixation. As I said, it forms more than 15% of all skeletal injuries. So it's really one of the most common fractures. It has a biphasic distribution in that in the young, it's usually a high energy injury. And in the elderly, it's usually a low energy fracture, but not always. Sometimes even in the elderly, you can have quite a high energy injury. So you need to be aware of that. Now, for most other injuries, we are talking about columns. So Rickley and Regazzoni also sort of proposed this 3-column concept of the distal radius and ulna, which is still fairly popular. There are multiple classifications available, including the AO classification, the Lichtman, the there are more CT-based classifications, etc., today available, but this is still probably one of the more popular classifications. And we talk about the 3 columns, the radial column, the intermediate column, and the ulnar column, which is the ulnar side of it. Okay. The other important thing is the orientation of the articular platform. Remember, there's a 11-degree volar tilt and a 25 degrees. So this is the volar tilt, which is 11 degrees, and the ulnar inclination, which is almost 22 degrees. Okay, and the height of the radial styloid as compared to the ulnar styloid is around 11 millimeters distal to the ulnar styloid. So this radial height. So in all the fractures, you have to try and restore this relationship. It's not always exactly these values. So it is useful where you have a normal opposite side to get an X-ray of the opposite side. So you know what you're trying to achieve in your reduction. So the aims of treatment are restoration of the articular surface, restoration of the radial length and tilt, and restoration of the radioulnar joint. And if you're operating, you also need to get a stable fixation. So the standard investigations are the AP and lateral. Remembering in the wrist, the AP is usually a PA, because you always put the hand flat on the X-ray screen and then they shoot from above. So it's actually a PA and a lateral. And the CT scans for intra-articular fractures has become something which is done more and more often, and probably necessary for some of the really complex fractures where there's multiple comminution, subluxation of the joint. So there are things you can see on the CT which you will never make out on plain X-rays. Okay, now when you're treating them, whether you're treating operatively or conservatively, you need to try and get a radial angle of more than at least 5 degrees. A palmar tilt should at least be neutral. You want it 10 degrees volar or 11 degrees volar, but at least it should be neutral. The ulnar variance should be comparable to the opposite side. The articular step-off should be less than 1 or 2 millimeters. The gap should be less than 2 millimeters. And the distal radioulnar joint or the distal ulna should be stable. So it should not be subluxating at the end of your reduction or fixation. So these are basic things that you need to try and achieve when you're treating these fractures. So there are multiple options which are there. You can do closed reduction, and closed reduction for these fractures is still a very valid option, especially for the elderly. There have been a number of studies recently showing that closed reduction and cast treatment has close to, the results are very similar to that of operative treatment and sometimes even better. Okay, you can do closed reduction with percutaneous pins. Remember, percutaneous pins is probably not a very great idea in very osteoporotic bone, but in the younger patient where you have nice fragments and you want to just avoid putting a plate, etc., this is an option. External fixators were very popular some time ago, but I think today with the advent of the lock plates, they are being used less, but we do use them sometimes as a supplementation to internal fixation, or certainly for open fractures where it's till you get the wound, etc., sorted out. It's a definite option. You have open reduction and internal fixation, which has today become the main method of treatment. Like I said, you can use combinations and adjuncts. Okay, how to decide which of the above will be appropriate for a given patient will depend on multiple factors. Okay, now, interestingly, if you look at the Cochrane review in 2004, they show that there's no difference in outcome whether you manipulate them or you do not manipulate them, whether you manipulate them late or early, position of immobilization, meaning whether you put it in volar tilt, sort of ulnar tilt or radial tilt or dorsiflexion, etc. The duration of immobilization, whether you use an above knee cast or a below knee cast, what plaster materials you use, doesn't seem to make too much of a difference in terms of the studies that have been done. This doesn't mean it doesn't make a difference. I think it is probably important to get a decent reduction, get the relationships right, and then you're more likely to have a good result. But the studies which have the Cochrane reviews, which very often don't show any significant difference between one method and the other, this is what they came out with in 2004. Okay, now, one of the things that you must be aware of is that if you treat them conservatively, quite a significant proportion of them, especially if there's comminution, tend to displace back to the original position. Now, in the elderly, this may be well tolerated, but in the young, if it redisplaces, then you should expect problems. And if you're not able to hold it in a cast, maybe operative treatment is better. The other issue with conservative treatment is the sort of high incidence of RSD or Sudex, or today what is known as chronic regional pain syndromes, the CRPS. And this may be related to basically the plaster getting tight and patients not moving, and very often some compression of the median nerve. So this is one of the theories put out, that a lot of the so-called CRPS that we get is related to early compression of the median nerve. Now, Lafontaine came out with a some criteria for judging instability. So they looked at a large number of patients and felt that if there was a initial dorsal angulation of more than 20 degrees, a shortening of more than 5 millimeters, if there was significant dorsal comminution of 50%, if there was an intra-articular radiocarpal fracture, if there's an associated ulnar fracture, or patients who were 60 years or older, this was all the factors which they looked at. And if a patient had more than 3 of these criteria, it was likely to fail casting. So when you're treating them with casting, especially where you want to maintain a reduction adequately, you need to look at these factors and then decide whether just casting will give you a good result. So this is the paper by Lafontaine in Injury 1989. It's quite an old paper, but still valid for most of the issues. And on the other side, looking at the same criteria, the indications for surgery would be the same sort of things. If you look at radiological signs of instability, if there's any intra-articular displacement greater than 2 or 3 millimeters, open fractures or compartment syndrome, obviously nerve or vessel injuries, again, come on to that. Secondary displacement in young patients, again, we talked about. If you get a decent reduction, but 1 week or 5 days later, you find that it slipped back to the displaced position, I think those are ones where you would have to operate. And then for late cases, for malunions or non-unions, you may consider surgery. Now, what are the indications for closed reduction and percutaneous pin fixation? I think these are stable fractures with displacement. So if you have a displacement, but when you reduce it, it's reasonably stable, especially in the relatively younger patient, you may consider closed reduction and percutaneous pinning. And like I mentioned, that sometimes we use an external fixator as an adjunct, or the pins as an adjunct to external fixator in some of these cases. And we still do that once in a while where there's some reason for not doing open surgery. So if you're planning to do closed reduction and pinning, it's important that you do it in a proper sequence. You stabilize the radial fracture, reduce it, correct the dorsal tilt, correct the radial inclination, and evaluate stability of the distal radio-ulnar joint. And if you find that is unstable, you may even put in a pin into the ulna, or if there's a radial ulnar styloid fracture, you may require to fix it either with a small tension band wiring, or today there are small screws available which you can fix it, or if it is just an avulsion of the tip, maybe a suture anchor. So these are various options that you have. So sometimes with young patients with relatively it's a displaced fracture in terms of the angulation, but not much shortening, not a significant articular step off, you can reduce it and fix it with pins, sometimes even pinning the ulna onto it. And this will give you a fairly stable, so you've got these two pins and a clasp, and this gives you a very stable fixation. The other technique of pinning is the intrafocal Kapanji technique, where you actually put in the K-wire through the fracture site, then use the pin to reduce your fracture and drive it through the opposite cortex. So you have a fracture that's displaced like this, you put your pin into the fracture, and as you tilt the pin this way, it will reduce the distal fragment, and then you drive it into the proximal fragment. And you can add additional pins once you've done that if necessary. So K-wire through the fracture site, lever up the cortex as required to reduce the fracture, and then pass the pin through into the opposite cortex, the proximal fragment, and then you can add pins as required to get you good stability. The advantage of this is it reduces the any chance of wrist stiffness as compared to when you put the pins close to the wrist joint. And again, so we talked about combination of percutaneous pinning with external fixator. I think if you have a situation where there's young patients with a lot of comminution, or in some of the older patients, you would percutaneously pin the fracture, get it into position, and then add an external fixator to give it length stability so that it can't collapse later. So this is one of the options. It's important not to leave the external fixator for long. I think most of the studies have shown that if you leave the external fixator, especially the static fixators, for more than 6 weeks, the chances are that you will get stiffness. The other thing is not to try and distract too much on the fixator. These again cause problems with features of stiffness and CRPS. Now, coming to open reduction and internal fixation, I think we all have the conventional plates which we used. And today we have the various sort of series of lock plates, which could be, some of them are for the volar side, some of them for the dorsal side, some of them are even for the radial side. And you also have fragment specific fixation, which you have to pick out which fragment you need to fix. And so this is important, and we've discussed that in a little more detail. So the volar approach is fairly standard. You go in the plane just lateral to the vessel between the flexor carpi radialis and the vessel, and then you sort of dissect out the pronator teres from the radial side across to the ulnar side. Okay, so once you do that, then the distal radius is there for you, and you can use various techniques to fix it. Even for a dorsally displaced fracture with the lock plates, you can use this technique where you put in your distal screws in a particular direction, lock them onto the plate, and then as you kind of straighten out the plate onto the bone, you're going to correct the dorsal tilt and you'll get a good reduction and fixation using this plate. So, and because the screws in the distal fragment are angle stable, it'll give you a good hold and fixation. Okay, so various examples. Here's volar buttons. This is one of the more or less close to an absolute indication for surgery, where you have the ulnar sort of carpal bones subluxing with the volar fragment, and you have these fractures which may or may not be comminuted, but this needs a buttress plating on the volar side. Make sure that you get the plate in a position that it will adequately buttress the fragment, and then you fix them using these plates. There are various plates. You can find one that suits you. There are various companies with these plates, but I think locking screw plates have really helped in this situation. The other thing you must be wary of is the watershed line, which is just distal to where the distal level of the pronator quadratus, and try not to get your plates beyond that, because that will cause problems with the flexor pollicis longus tendon. Obviously, there are some situations where you need to do that, so you have to be careful about that. Try to use low profile implants if you need to go more distally rather than high profile implants. So again, you can have a lot of combination. You can have involvement of the radial styloid. Here's a dorsal tilt. Again, these fractures can be managed from the volar side. Today with these plates, you have the ability to fix these various fragments. You need to make sure that you get a good reduction. If you have a fracture involving this intermediate column, especially the dorsal lip of the intermediate column, that is one situation where you may have to go and use a dorsal plate. So this is the one which I showed earlier, showing a good functional result at the end of the follow-up. Okay, here's another one. Again, it's a volar fragment. There's an intermediate column as well as the radial column fracture. Those are the CT scans showing the displaced fragments. And again, it's fixed with a plate. You can see it's been reduced adequately. The follow-up showing that, again, the tilt, the radio-ulnar displacement relationship is all maintained. Now, when you get more and more distal fractures, that's where sometimes you may need to either go very distal with the plate or use some supplemental fixation. So here's the fracture reduced. We've used the K-wire for the to fix the styloid, put on the volar plate, and then we're also putting a radial styloid sort of plate on the lateral column to fix the lateral column. And so that's the reduced position. Again, shows a good reduction in that situation. Okay. So default approach is anterior, but there are certain indications for a dorsal approach. One is if you need to see the joint. Okay, so this is something that you, on the volar side, you don't want to, thick ligaments and capsule, which you don't want to divide. So if you need to see the joint, the dorsal side gives you a much better approach. If you, like I said, if you have a dorsal shear fracture, especially involving the sort of intermediate column or the sort of lip or the sort of rim of the dorsal column, those would need approach from the dorsal side, and some radial styloids, although you can approach the radial styloid from the volar side as well. Now, depending on where you need to fix it, you can go between the first compartment and the second compartment, or between the third and fourth compartment. So depending on that. A word about the X-ray views on the table. I think it's important that you get proper views. And if you don't do the proper views, so if you take a X-ray with your hand flat on the table, very often you will see that the screws look like they are in the joint. If you raise it up a little bit, because of the, again, tilt in the dorsal part, you'll find that the screws are not in the joint. Similarly, in the lateral view, if you put your sort of wrist flat on the table and take a lateral view, because of the radial inclination, it might look as if some of the screws are in the joint. The same thing, if you lift it up a little bit, you will find that the screws are not in the joint. The other important view, especially with the locking plates, is the tangential view, which you take with the wrist in this position. So it's a dorsal tangential view, and this is important to know the length of the screws. Okay, the reason for it is that when you do the lateral view, you have the sort of projection of bone here. Okay, and this may mask the fact that screws here can be outside the cortex, but the lateral view will show that it's within the cortex because there's a projection of the dorsal styloid, the dorsal rim of the distal radius. Okay, so that tuberosity on this dorsal side may project, and your screws, which are actually out of the bone here, will still look that they are in the view. So this is a view you take. This is known as the dorsal tangential view to make sure that your screws are of the right length. Now you also have what we talked about, the fragment specific fixation concept. And here you need to look at the radial column, the intermediate column, the dorsal wall fragment, and very often this may need some special type of fixation or some wires which you can turn around and put under the plate. So there are a number of ways to deal with these fragments. And the volar rim fragment. Again, the volar rim fragment in the intermediate column, very distal, can be tricky to try and reduce. Okay, now the complications that you can get. So if you have your plate very distal, like I said, beyond the watershed line, you may get rupture of the FPL tendon. If your screws are long, then you can get rupture of the extensor pollicis longus or even one of the other extensor tendons. And you can get impingement pain on the prorator quadratus as well. So some of the literature shows the results between comparative results between operative and non-operative treatment, and these are depending on where the study is from, shows good results with operative treatment, and others show in the elderly show good results with non-operative treatment. Now, one of the newer developments is this concept of the distraction plate, where there's a lot of metaphyseal comminution or even articular comminution, where you use a plate in a distraction mode like an external fixator, and you can go to the second or third metacarpal depending on where you feel the bone is best lined up. Okay, so and this you can now do through minimally invasive approaches as well. And this is how the plate goes on to 3 screws on the metacarpal, screws on the distal up to the radial shaft, a bridging area, and you can even put intra-articular, screws for the intra-articular fragment using this technique. Okay, so this is an example of a case where we used it. This was a 46-year-old lady who was involved in a road traffic accident. It was an open fracture which was managed elsewhere. Was treated with debridement and an external fixator. And she came to us with severe pain and stiffness of the fingers. There was a clear-cut CRPS, but no obvious infection. So the SED rates, etc., were normal. There was no pus there, although earlier she had, but she had a clean operative wound, and you can see the swelling in the hands and really stiff. She could hardly move the fingers at this stage. And so we thought we can't put a fixator on again. So what we did was approach it from the dorsal side after removing the fixator, use an LCP plate as a spanning internal fixator, and all the gap in the bone here we put in bone graft. So you can see the 3 screws in the proximal fragment, 3 screws in the metacarpal, bridging this whole area, extracting it out to length, and then filling it with bone graft. And then after 6 weeks, the plate was removed, and then the fracture had healed. This was her at 9 months post-op, still not regained full movement, but by about 1.5 years post-op, she had regained quite a good range of motion and a reasonable function, considering the difficult situation that she was in. And that's a 3-year follow-up. Again, you can see how the fractures are nicely united, and she's got quite a good function by this time. So I think this is a useful technique which you can use for fresh fractures as well as for some late cases when they come to you. I think with that, we come to the take-home message that I think different types of distal radius fractures have different personalities and prognosis. The treatment depends on the fracture type and the surgeon's experience. I think lock plates have certainly improved our ability to fix these fractures, and you have now multiple plates available which you can use to either treat the entire distal radius fracture or one specific column, add additional plates if necessary. You can even do dual approaches. That means you go volar and dorsal, and this is necessary. Not often, but I would say once in a while, you may have to use dual approaches. And again, like in any other surgery, the way to avoid complications is to anticipate them and then try to do your steps in such a way that you do not have the complications that you're aware of. Okay, but I mean, that doesn't mean you'll never have complications, but you can certainly reduce the number of complications that you have. Thank you.
Thank you so much, sir. We have few questions in the chat box, sir.
Sure.
First is Dr. Vinas want to know, does a distal radius go into non-union? How do we approach a distal radius non-union?
Yeah, so it's unusual for non-unions. Malunions are much more common, but we have seen distal radius non-unions. We've treated quite a few, I mean, not quite a few, but a few of them. Probably get about 1 or 2 a year. And I think the basic management is very similar. So we are talking about aseptic non-unions. Infected non-unions, again, a different kettle altogether. So the aseptic non-unions, you would need to, again, try to get the length of the radius right. If necessary, you may need to shorten the radius because if it's late, sometimes it may not be possible to get the length right. You have to restore the radio-ulnar relationship, put in bone graft, and then fix it with a plate as stably as you can. Now, to get a stable fixation, you need adequate bone distally. Okay? So if you don't have adequate bone distally, then you may have to combine it with an external fixator or this spanning plate that we talked about. Okay.
So Dr. Sachin wants to know, what if distal radius fracture associated with ulnar styloid fracture?
Okay, so I think this is something that has gone through a lot of changes in the last decade or so. Initially, it was dependent on the size of the styloid fracture. So people said if it was a large fragment or from the base of the styloid, you should fix it. Today, the general concept is that once you've got your distal radius fixed, make sure your distal radial ulnar relationship is okay, and then check for stability of the distal ulna. So you use the ballotment test. And if that is stable, then you don't need to fix it. If that is unstable, or if the styloid process is quite large, or if there's a distal ulnar fracture, or there's a subluxation, then you need to deal with it. So if there's this large fragment of the ulnar styloid, you would fix it. If there's a distal ulnar fracture which is unstable, you would fix it. If there's a displacement, usually you would put a sort of a radio-ulnar wire, leave it for about 4 to 6 weeks, and then take it out. Okay.
And so you have mentioned about that fragment-specific fixation. So do we have some fragment-specific fixation for this ulnar styloid, or how to fix that one with the K-wire? Or?
So ulnar styloid, I showed you can use a tension band wiring, or you can use, nowadays they're very small screws which you can use. Or if it is really very small, then you use like something like a small suture anchor. Okay.
And so there are quite a large number of cases have TFCC injury also. The incidence is more. So for that one also, we should do something with.
So if there's TFCC injury, there'll be instability of the distal radio-ulnar joint. Okay. Now, there's one further method where you scope the distal radio-ulnar joint, but by and large, it's still not become a standard practice to scope the distal radio-ulnar joint and see if there's an injury and then do necessary reconstructions as appropriate on that. But by and large, the consensus today is to fix the radius, check your ulnar stability, and then decide if you need to do anything on that side.
So there is another question by Narayan. he want to know about how Kapanji method of pinning is helpful in mid-lung deformity.
Mid-lung deformity, that is a totally different thing. There you have to do an osteotomy, okay?
Yes.
So if you do an osteotomy, you would do it in a position where you can fix it adequately. You can fix it with a Kapanji pin and then add additional pins. So it's intrafocal pinning, that is Kapanji technique. Okay. There's another thing called the Suave Kapanji technique, which is different. That is, you do a ulnar resection. You do a sleeve resection of the ulna and fuse the distal radio-ulnar joint. Okay. So that's a different thing from the Kapanji intrafocal wiring technique that we talked about here. Okay, so we do that for some malunions as well, okay, where the distal radio-ulnar relationship is not maintained or the pronation supination is restricted. So you could, if the problem is only of ulnar length, then you can shorten the ulna and fuse the distal radio-ulnar joint in the correct position, or combine it with an osteotomy of the distal radius if the distal radius is also, the tilt is not satisfactory.
So when we say the intrafocal, it means through the fracture.
Yeah, intrafocal Kapanji technique of pinning is a pinning through the fracture. The Suave Kapanji sort of treatment for malunions of the distal radius is different, where you fuse the distal radio-ulnar joint and take off a segment of the ulna so that you can get pronation and supination.
The question asked by Manish Sharma, he want to know, does Wharton fracture can be treated with Jess fixator?
So what is a Barton's fracture? It's a intra-articular fracture involving the volar lip of the distal radius. Okay, so it's a fragment involving. Now the idea is that you need to reduce it and stabilize it. Okay, so the best method for it would be like a buttress plate on the volar side. Now you can treat it with a Jess, but you'd probably ideally have to put a wire to hold it and a Jess fixator to hold the thing. So there's no such thing that you can't treat it, but is it ideal for it? Probably not. Okay. There are other ways you can put in multiple pins and put an external fixator, whether you use Jess or some other kind of fixator, that is your choice. Okay.
So question asked by Dr. Kumar Gautam. First one is, as distal radius fracture are predictor of osteoporosis, can we should start a anti-osteoporotic treatment?
Yeah, so if it's an osteoporotic distal radius fracture, certainly you should be treating the osteoporosis as well. Okay, so just like in neck femur fractures or trochanteric fractures, ideally it should be the orthopedic surgeon who initiates the treatment for osteoporosis. Now, where you have specialists dealing with it, you need to let them know and let them deal with that. But otherwise, in most towns here in India, you probably will be the one who will be treating the osteoporosis also.
So role of MRI in distal radius fracture.
So I think in fresh injuries, it's not much. I think MRI is of value in where you're looking for things like scapholunate dissociation, chronic radio-ulnar joint problems. Okay, but for fresh fractures, I think the CT is more helpful. But I'm sure that with time, the MRIs also now tell you a lot about the bony injury. Okay, but by and large, CT gives you more a better idea of the bony injury. Okay? But there are theories that most of these injuries are actually osteoligamentous disruptions, and so I think it's a matter of time before MRIs may also become a standard investigation, but not yet.
So another question, he want to know about cotton lauder casting.
Sorry?
Cotton lauder casting is asked the next question. One type of casting. No. Um,
It's a casting index, okay?
okay.
That is described by Cotton, which is where you have to make sure when you're putting the cast on, the cast is sort of, the index is the relationship between the anteroposterior thickness and the sort of transverse thickness of the cast, okay? And so if it's like a round thing, then that cast is unlikely to hold the distal radius as well as if it is nicely molded and flattened out to suit the, so there's a Cotton index that you talk about, which should be around 0.8 or something like that. So it should be thicker, I mean, in the transverse diameter than in the AP diameter.
Another thing is if after close reduction, again fracture gets displaced, can we retry close reduction or we should go for open reduction?
So it depends on if it's a young patient or an elderly patient. In a young patient, certainly you need to do it again. But if it is going to displace, then maybe you're better off operating on that because you don't want to keep doing it again and again. In an elderly patient, the general feeling is that even if it does displace with time, the patient gets back a decent function, okay, because the demands are not so high. But watch out for things like CRPS, what do you call as today? Very often they end up with stiffness of the fingers, etc., which are a much bigger problem dealing with than the fracture itself. Okay, it's important that you mobilize them early and watch them early. So if they're having a lot of pain in the cast, that's the time you need to either split the cast, change it, so that you have a comfortable cast where the patient can mobilize the fingers. A lot of the problems happen because in the first couple of days, the cast is a little tight and then the patient doesn't move the finger and then they develop full-blown CRPS. Okay, and sometimes there's median nerve compression as well, which adds to the problem. So I think it's important in the initial part that you make sure that the patient is able to mobilize the fingers. And this is one of the most common problems we see in our clinic is patients who've had distal radius fractures treated in a cast. The position may not be so bad, but they end up with cross stiffness of the fingers, sometimes of the shoulders, the classical shoulder and shoulder syndrome that they come with. And then it takes a long time to get them better. Okay, you end up having to give them various medication, sometimes even sort of plexus blocks, etc., to get the movement back.
So, I've seen whenever you opt for a close reduction and casting technique, every week you used to take call patient for the follow-up. So, can you please explain the protocol, sir?
No, I think not every week, but certainly after 1 week or 10 days, you must do another cast, especially in the young patient, because you don't want it to. After that, it's less likely to displace. Okay, so and then you can do it after 3 or 4 weeks.
What is the difference in management of intra-articular, extra-articular, and radial shortening malunion?
Okay, so intra-articular fractures and extra-articular fractures. So here the difference between whether you can manage with closed treatment or you need open treatment to reduce the articular step-off or gap. So more likely to need surgery for intra-articular fractures than extra-articular fractures. More likely to manage with percutaneous spinning, etc., for the extra-articular fractures. Whether shortening in a malunion, that's a different thing. It's a whole subject in itself. It depends on the situation, how late it is. If it's early enough, you can actually get back the length by doing an osteotomy, bone grafting, and get the radio-ulnar relationship right. If they come very late, then you may have to correct the tilt, but you have to shorten the ulna. And in the elderly, it may mean something similar to a Darex, although today we don't do a classical Darex. We tend to leave the ulnar styloid there and excise the distal radius part of it. So that's another option for a malunion, which is troublesome, where the main problem is a sort of subluxation or lengthening, relative lengthening of the ulna compared to the radius. Intra-articular malunions, now they are osteotomies where you can do intra-articular osteotomies. Again, it depends on where the problem is, how late they come, whether they already got an arthritic joint or not. And if the joint is already arthritic, then you have the option of, if things are really bad, then you end up having maybe intra-articular injections, etc., to relieve the pain. Okay, so it depends on the situation, what you would do in those cases.
So sometimes patient comes with that carpal tunnel syndrome may be associated, or even after the reduction, 3 or 4 days after the reduction, it may have symptoms of that. So in those cases, sir, what to do?
I think in those cases, if there's a clear carpal tunnel syndrome, you should be decompressing.
Even like
if you don't, they'll end up with problems later.
Another question you want to know is how to prevent RST.
So that's what we talked about. One is make sure the cast is not tight, start early mobilization, make sure there's no compression of the median nerve. If they're having a lot of pain, see what the problem is and deal with it. So I think the tight cast and median nerve compression are the two most common causes of them developing RSD later.
Okay,
probably
so, yes,
from clinical experience, not based on literature.
Okay. So do we should put patient on vitamin C in case of like close reduction after? For that one, in every case?
There is some literature to show that vitamin C helps. I mean, we don't do it I tend to give a lot of my patients vitamin C anyway. So I probably give them vitamin C, but it's not based on any direct evidence on that. But certainly, I think our diets in general are deficient in a lot of vitamins, and it's no harm to supplement them. But I'm not. There is some literature on the use of vitamin C, but it's not yet something that everyone does.
So, dorsal tangential view and skyline view, both are same or not? That one question Dr. Gautam has asked.
So the dorsal tangential view is what we showed you.
Yes.
In the view. Skyline view, I'm not sure what you mean by skyline view, because there is another tangential view where you do with the wrist dorsiflexed rather than palmar flexed as it was in this case. Okay. Some people say that is better to see the length. Some people say this is better. I don't think there's much difference. I'm not sure what you mean by skyline view. So Gautam, if you know what you're talking about, tell us what you mean.
No, sir. Good evening, sir.
Yeah.
I don't know about skyline view in detail, sir. Just read in Arthroplasty, sir. It is used to see the dorsal cortex penetration of the screw, sir.
So then it will be the same thing. Okay.
Yes, sir.
So you mentioned about volar and dorsal lip fracture, especially intermediate column should be fixed. Why this is so important, and what approach is best for such rim fractures?
So I think it's important because the load transmission through the lunate goes through the intermediate column. Okay. So if you have displacement or comminution there, you're going to have problems. The approach will depend on whether it's volar or dorsal. These rim fragments, if they're dorsal, there are percutaneous ways of dealing with it, but otherwise you have to deal with it from the dorsal side. The volar rim fragments you'll deal with from the volar side.
Okay. So I've seen when you lift the Dupuytren's fracture. So after that, when we are using the locking plate, do we need some bone graft or bone graft substitute for that, or if so, which one you prefer?
So I think if it's an elderly patient with a very soft bone, and they have a significant gap after you've done your sort of reduction, then maybe there's a need to put in some bone substitute. Okay? Now, there are different methods available. There's an injectable paste type, or there's a granules or powder or whatever. Huh? That's a matter of choice. I don't think there's any evidence to show that one is much better than the other. But it's when you feel that your fixation is not adequate to hold the length and you think you need some kind of support. So it's not common in fresh cases, but yes, there may be situations in the elderly where you might want to do it.
In young patients, yeah.
Young patient, it's rarely necessary. Yeah.
Okay, sir. And is there any emergency in case of this distal
So
resistance?
if you have median nerve compression, that's an emergency. If you have compartment syndrome, that's an emergency. You can have a hand compartment syndrome. Okay, and you can have, what else? You can have a vascular injury. Okay, so all these are emergencies. Yeah? Pediatric fractures. Okay, so pediatric fractures, most of them can be managed conservatively. Okay, if you have a sort of Salter-Harris type 2, which is the common one, usually it will be conservative. If it's a type 3 or 4 where they're rare in the distal radius, those may need some kind of sort of interfragmentary fixation of the articular area. Pinning for displaced fractures which are unstable. Okay, but try not to go through the physis where possible, but for some of them you may have to. Remember that there have been reports of physial arrest where you put in pins through the physis, especially if you make multiple passes of the KY. So if it's a more proximal fracture, try to avoid the physis. If it's quite distal and it's unstable, you may have to go through the physis, but then try and do it in one shot rather than multiple shots, and don't use very thick wires for that.
And so when to order a CT scan in distal radius fracture, because we have seen few of the cases which are undiagnosed intra-articular fracture in the slab, and that will.
So like I said, like most other things, it's if you have it conveniently there available and you have an intra-articular fracture, or you suspect an intra-articular fracture, then it's probably worthwhile getting a CT scan. Okay, usually even if you may not see it on the X-ray clearly, you will suspect it on the X-ray. If it's extra-articular without any intra-articular involvement, you will be able to tell on the X-ray as well. So there are these borderline cases where you think it's going into the articular surface, but you're not sure. That's where you do it. Or if there's an intra-articular fracture with comminution or significant displacement, then certainly you need to do it.
In conservative, when we are opting for conservative treatment, you ask for the early range of motion exercise and other joints movements. In case of operative treatment, sir, what should be the advice post-operatively?
So I think the aim would be to not have to put a cast at all and start early movement. Okay. But if you have some doubts about the stability of the fixation, then you may have to protect it for some time. But at least the fingers you should mobilize straight away. Okay. So even if you put it in a cast sometimes for 2-3 weeks, start early, put it in a functional position and start early motion of the fingers.
And when?
Yeah.
Yes, sir, when?
Slab on for 2 or 3 days just for the swelling to subside. But I think you have to judge for yourself how stable your fixation is. And the aim would be to get stable enough fixation that you don't need a cast. But there will be situations where, in spite of your fixation, you feel a cast is probably you're not fully secure about your fixation. Then in the wrist, putting a cast for some time doesn't seem to cause too much problems.
And sir, when we are, if the construct is stable, we should start the wrist joint movement in after 2 to 3 days, like.
Yeah, absolutely.
So, and
a lot of them we don't even put a cast at all. So ones which we are sure about the stability. Like most of them, we don't give a cast. Some of them we use a slab for some time. And some of them, which we are a little worried about the fixation because of very distal fractures or comminution, we might keep in a cast for something, 2 to 3 weeks or something.
So when we are opting for percutaneous pinning, so the number of pins, how to decide how many pins and
I think you have to look at the fragments again. So if you have you need to, if there's a radial styloid, you need a separate pin. If it's a volar tilt or a dorsal tilt, you need a separate pin. If there's a distal radius ulnar involvement, you need a separate pin, and then you can add more if you think it needs more stability. But pins you put in close to the joint, again, the risk of stiffness occurring increases. So you have to get good stable fixation with the pins, otherwise you will get problems. At the same time, if you put too many pins, you can have problems with soft tissue being sort of transfixed, etc.
So there are a little confusion about when we have to look for the radial styloid fracture. Do we have some views in the X-ray, because sometimes it is very difficult to intraoperatively.
If you're confused, get a CT scan. I think the views are going to tell you much about the styloid specific. You get the standard epilateral, and if you're thinking of scaphoid, then the sort of ulnar deviated view helps, and the oblique views help. Maybe the oblique views might help you with the styloid also, but CT would be really the most useful thing there.
So the duration of cast after close reduction.
So I think in elderly patients, 3 to 4 weeks for a simple fracture. Younger patients, 4 to 6 weeks, I would say. 6 weeks maybe.
So one last question: when to say the fracture is stable or unstable?
So if they talked about the criteria, the TENS criteria, I think that's a good way to go. Look at the displacement, the comminution, and the age. Okay?
And one more question is how to suspect TFCC injury in distal.
We discussed this already, that if you have any displacement, okay?
Yeah, DRU.
Any instability of the DRU, it could either be a styloid fracture or a distal radioulnar subluxation or TFCC. So TFCC injury per se is more difficult to diagnose on a distal rate. So that's more a chronic issue that they come up with later, and then you need to do an MRI, or the other way is to do an arthroscopy.
So one more question Dr. Deepak Kumar has asked is in osteoporotic patient with distal radius fracture, when to start osteoporotic medication postoperatively?
So you can start straight away. Okay, so any of these bisphosphonates don't actually take effect in the bone for 3 to 4 months. Okay? So there's no reason to delay it for fracture healing. Okay.
So I think most of the questions we have covered. So thank you so much, sir. And
okay, great. Thanks. Thank you.
Thank
It's 8 o'clock. So thank you very much.
Yeah.
And I hope it went off okay. Okay, bye.
Thank you.
Thank you, sir.